So here's another really interesting concept called suspended animation. It's also known as emergency preservation and recovery. And the idea behind this is that patients have hypovolemic cardiac arrest, so they have loss of blood volume. And the classic way this happens is trauma, and especially penetrating trauma. So the most common penetrating trauma that we see in a city like Philadelphia, unfortunately, is gunshots. And so these are young, usually patients, most commonly male, and they've had one or more gunshots, and those gunshots have injured usually an important vessel in their body. So the blood is leaking out of that vessel, and they develop hypovolemia, low volume, low blood volume, and they go into cardiac arrest. So in 1984, Peter Safar, who spent most of his career at University of Pittsburgh and is really the father of resuscitation science in America, and also the person who pioneered therapeutic hypothermia as a treatment modality for people after cardiac arrest. Peter Safar and Dr. Bellamy came up with this idea of suspended animation, and they defined it as rapid preservation of viability of the organ in temporarily unresuscitatable cardiac arrest. So unresuscitatable cardiac arrest, someone that they can't get return of spontaneous circulation in. And it's very hard to get return of spontaneous circulation in someone who's had a cardiac arrest from penetrating trauma, because the blood's just leaked out of the vessels, there's no blood coming back to the heart, and you can't get return of spontaneous circulation when there's no blood to carry oxygen to the tissues. So what they decided was that they would figure out a way to immediately put these people into deep or profound, these initially animals, an experimental model, but the goal is to be able to do this for people, into immediate or profound hypothermia, then use pharmacology to protect their cells and give time for surgical repair of whatever injury led to this hypovolemia, hemorrhagic shock, and cardiac arrest. And obviously, you know, the one of the groups that's really interested in this is the military. And so some of this research has been funded by the Department of Defense, and they're really interested in the ability to save soldiers who have penetrating trauma from gunshots during wartime and are otherwise healthy people who could be salvaged if we could figure out how to do this. And so in 1988, Sam Tischerman at Pittsburgh and other colleagues there came up with a dog model of emergency preservation and recovery. And so what are we talking about with deep hypothermia? So normal thermia, what we are, if we're maintaining a normal temperature, is 37 degrees centigrade, so about 98.6 degrees Fahrenheit. Mild hypothermia, 34 to 36 degrees, and moderate is when you go under 30 degrees. So right now the target range for therapeutic hypothermia that we use at Penn and at other institutions around the world is 32 to 34 degrees Celsius. So that's in the neighborhood of 90 to 93 degrees Fahrenheit. So a little bit of a temperature reduction. The deep hypothermia and the profound hypothermia that they're talking about for emergency preservation and recovery is down in the 5 to 20 degrees Celsius range. So much lower, getting down almost toward the freezing point. So I'm just going to show you one study that they've done. They've done multiple studies. A lot of them were done at Pittsburgh with Peter Safar's group, and then other people have followed up those studies. So this is a study where they took 14 dogs and they were exsanguinated, so bled, for greater than 5 minutes, losing the majority of their blood volume, and then they go into cardiac arrest. And they came up with equipment that allowed them to rapidly flush the blood vessels with chilled saline that was at 2 degrees centigrade, that was put into the femoral artery, and that was started at 2 minutes into the cardiac arrest, and they continued that flush of saline until the animal was in profound hypothermia at 10 degrees centigrade. Then they took these animals and they randomized them to either no trauma or trauma. And the trauma was a laparotomy, which is opening the abdomen, and a splenic injury prior to exsanguination. So these animals were actually randomized before this exsanguination. And then after the cardiac arrest, they had a thoracotomy, which means their chest was opened, and then their spleen was removed. So basically, this is a model of a splenic injury, so someone who had a gunshot to the abdomen, it hit their spleen or the splenic artery, they were bleeding from that, they bleed until they arrest, and then they get the therapy that would happen in the trauma bay, a thoracotomy. That person would come into the trauma bay, their heart stops beating, the trauma surgeons, the standard of care is to open the chest and try and get the heart to beat again, and then they go to the OR and they get a splenectomy. So this is a very realistic model of exsanguination and cardiac arrest. And then they resuscitated these dogs after 60 minutes of no flow. So this is 60 minutes where the animal's at 10 degrees centigrade, the heart's not bleeding, beating, and there's no blood flow in the body. The cells are just sitting there in that period between life and death, and then they resuscitate them, they put them on bypass, you use that to produce blood flow and oxygenation, and then they defibrillate them back into a normal perfusing rhythm. And this is what they found. All of the control animals, after 60 minutes of no flow at 10 degrees, were able to recover to normal. So these dogs were able to eat, walk, hunt, fetch, do all the things that dogs do normally. And you can see, even when they had the splenic injury, got a thoracotomy, and their spleen removed, they were still able to get 4 out of the 8 animals back to normal, and another one with moderate disability. So this is very exciting research where they're showing that there can be a period of no flow in complete ischemia, and then you can recover from that if the cells are protected by being cold at that time. So the Department of Defense, as I said, is very interested in this, and the protocol is in place to do a human trial of this. And there's 5 trauma centers in the United States, and the goal is to treat 50 patients who otherwise would be pronounced dead. So these are patients with penetrating trauma who lose their pulses, who go into cardiac arrest in the trauma bay. Their heart's opened, they see if they can get the heart restarted, fix any injuries that way, and if they can't, then they would flush those patients with cold saline and lower their temperature to 10 degrees centigrade, and then go to the operating room and see if they can fix the injuries. And even if they had 1 or 2 or 3 patients survive out of these 50, you're talking about patients who otherwise have 100% mortality. So if you could get neurologically intact survival, this would change the paradigm of what is life and what is death in trauma patients. So this is very exciting preliminary animal work, and the human studies are about to start in a few select trauma centers in America to see if this can actually be done to humans who are dying of penetrating trauma and cardiac arrest. So that's really exciting research, and we'll see over the next 5 or 10 years what the results of that study are. And so lastly, we want to just talk about regionalization, and this is the idea that cardiac arrest is a complicated disease. We've talked a lot about the complexity of intra-arrest care, and then the increased complexity of post-arrest care and the whole post-cardiac arrest syndrome, and how we need a whole bundle of care to take care of these patients. And the idea of regionalization is maybe this should be done at select centers that can deliver this whole bundle of care in an expert fashion. So let's look at this a little bit. So here's the United States, the 48 contiguous states in Alaska and Hawaii, and it's estimated that there's about 300,000 out-of-hospital cardiac arrests each year in the United States, and then there's maybe another 100,000 that occur in the hospital. In about 50,000 of these arrests reach the hospital with a pulse, so that's only 1/6 of them, somewhere in the neighborhood of 17%. And we looked at the Penn data, and we showed you that, originally patients brought to us, about 34% of them had return of spontaneous circulation. So this is 17% of all these patients reaching the hospital with a pulse, and there's 5,000 hospitals in the United States. So if these people were equally distributed to all the hospitals, which we know is not going to be the case because of population density and stuff, that would mean that there were 10 arrests per year per hospital, and that have return of spontaneous circulation. And what I would argue is that's not enough patients to learn how to do this care expertly. So the problem here is that some hospitals are going to lack experience in this. And this is especially true. You're going to get some hospitals getting 100 arrests a year and some hospitals only getting 2. And so these hospitals that get 100 should be able to give better care to the patients. So that's what we're thinking about. That's sort of the problem one of post-arrest care, is that there's hospitals that lack experience. Problem two of post-arrest care is many hospitals have no catheterization lab, meaning they can't take someone having a heart attack to the lab, open up the vessel by putting a stent in, and restore blood flow to that patient. So if we know that, especially patients who arrest from shockable rhythms, that a large percentage of them have a coronary artery that's blocked and they need to go to the cath lab, does it make sense to take these patients to a hospital that has no cath lab? Many of these hospitals don't have any hemodynamic management strategy. We've talked about letting the brain recover, and we think one of the keys to that is perfusing the brain appropriately, delivering the appropriate amount of blood pressure to the brain, and letting the brain recover. And you have to have a strategy for that. That strategy involves being able to do echocardiograms of the heart to see if the myocardial stunning we talked about develops, being able to do invasive monitoring of these patients, measure their oxygen consumption. Many hospitals cannot perform EEGs easily. They can't do continuous EEGs. These are electroencephalograms that measure the brainwave activity and look for seizures. And many hospitals are not expert in neurocritical care, the management of neurologically injured patients. And the ability to prognosticate about these patients and to say this is what's still treatable in these patients is a difficult thing, and you need to have expert care in that. And then many of these hospitals in the United States don't have 24-hour, 7-day-a-week intensive care physicians available to take care of these patients. And these patients arrested any time of day, and they're sick through the day and the night. And what we would argue is that you need to be able to give care 24/7, 365 days a year to these patients that's the same at any time of day. And this is not saying that these aren't good hospitals. It's just saying that some hospitals don't provide the essential aspects of the bundle of care. They don't have the resources to do that. And so maybe these hospitals aren't prepared to take these patients. Then the third problem in post-arrest care is that currently, in most places in the United States, the EMS, the emergency medical services, are designed to bring arrest patients to the nearest hospital, not the best equipped hospital for these patients. But because post-arrest care is complex, maybe what we need to go toward is a bypass model, and the classic model for that is trauma. So a patient with a gunshot wound, like we were talking about when we talked about suspended animation, those patients aren't brought to every hospital in America or to the nearest hospital. In general, those patients are brought to a trauma center. And maybe we need to have the same bypass model for cardiac arrest as we do for trauma. So The third problem, I would say, in the regionalization debate is that EMS brings patients in cardiac arrest to the closest hospitals. So to look at this differently, maybe the solution is regionalization. And this is not a new concept because we do this already. We do stroke center care where patients who are having a CVA, a cerebrovascular accident, are taken to stroke centers. They aren't taken to any hospital. They're taken to a place that can deliver them potentially life-saving care in a timely and systematic fashion. Trauma centers we've already talked about. Gunshots are taken to trauma centers. Car accident victims are taken to trauma centers. And patients who have falls and other injuries are taken to trauma centers if they're injured enough. Same with burn centers. We don't take patients with severe burns to any hospital. We take them to centers that are expert in burn care. So this is being done in the United States, and this is just in the early phases now. But would like to tell you about a few places that have done initial attempts at regionalization. These include Arizona, Minneapolis, New York City, and we're starting to do this in Philadelphia as well. Also, some hospitals are saying, well, let's move the therapeutic hypothermia to the pre-hospital setting. And so as soon as there's return of spontaneous circulation, they start treating the patients with ice saline. And in fact, some people are starting to do that during the arrest. Now, there's a lot of data that suggests we can do this, but the data that suggests that it changes outcomes in patients is not as strong. So let's look at the Arizona experience before we wrap up here. And so in Arizona, they basically said, you know, we're not doing very well with cardiac arrest outcomes, and we're a state that has a few large urban areas and then a lot of open space, a lot of long transport time. So maybe we should really start thinking about how we deliver care in the pre-hospital setting to these patients, and maybe we should establish cardiac arrest centers. And what they decided was that to be a cardiac arrest center, you had to be able to go to the cath lab, what we call PCI, percutaneous coronary intervention, to treat a blocked coronary artery. You had to be able to do therapeutic hypothermia on these patients for optimal post-arrest care. You had to be able to collect data on the patient so that you could monitor, just like we talked about. You have to know what your baseline is. And then you had to have a protocol to stop treating patients if they weren't going to recover. And so those were the bundle of things that went into being a cardiac arrest center. And this was voluntary. They didn't choose the hospitals. They said any hospital can do this if they're able to do those things. And then they put together EMS bypass guidelines, and those were approved in May of 2008. And then they started taking patients to only the voluntary cardiac arrest centers in Arizona. And what you can see here is in blue is the in cardiac arrest center survival, and then you can see the post in orange here. And what you'll see here is that there's markedly improved outcomes in these patients when they changed to these cardiac arrest centers. So for all rhythms of arrest in Arizona prior to developing these cardiac arrest centers, so this is for ventricular fibrillation, PEA, pulseless electric activity, and asystole, where there's no activity of the heart at all. For all those rhythms, they had 11% survival in Arizona, in the state of Arizona. And they doubled that when they went to these cardiac arrest centers. And they also started doing better quality CPR during this time too. And one could argue that you can do better quality CPR if you're also bringing these patients to centers that can take care of the patients. You can see for the non-shockable rhythms, the PEA and asystole, they had some increase in outcomes, but these people don't do as well as the shockable patients. And we talked about why this is. We talked about early defibrillation, the ability of chest compressions to get the heart ready for another defibrillation. And look at what they were able to do with witnessed out of hospital ventricular fibrillation arrest. So someone sees this person arrest, they're in a shockable rhythm, and they get treated at a cardiac arrest center. They were having 20% survival prior to starting this, and they doubled that to almost 40%. So 2 times the survival. So this suggests that a whole comprehensive intra-arrest protocol and cardiac arrest center transport protocol with therapeutic hypothermia is able to markedly improve outcomes in at least one state in the United States. And this is really a model for doing this in other parts of the United States as well, and part of how we're thinking about this as we think about regionalization in the Philadelphia area. So what have we done here? Well, we have at Penn, we have Penn Star, which is our flight helicopter program, and it also has ground ambulances. And here's Philadelphia down here in the southeastern corner of Pennsylvania. And we have 6 helicopters, and they can fly in a 100-mile radius around the city. And most hospitals in the area have helipads. So in theory, if someone has a cardiac arrest and they're at a hospital that doesn't do therapeutic hypothermia and other aspects of post-arrest care, we can fly there and get that patient, bring them to Penn, where they can get a comprehensive post-arrest protocol given to them. So this is a brochure that we give to hospitals that are interested in transporting patients to Penn, and these are all patients that we've treated at Penn who have survived their cardiac arrests, being treated with our bundled post-arrest care, and a couple of these patients have been transferred to us by helicopter from other hospitals that did not do post-arrest care, or from the scene when the emergency medical services command physician said, bring them to a cooling center, and they were brought to us. So this is the beginnings of post-arrest care being regionalized in this area as well, and we're hoping that soon every patient who needs to receive post-arrest care will be transported to us or to other centers in the area who can do this life-saving therapy. So we've talked a bit today about the future of cardiac arrest, and we've gone through this idea of the 3-phase model of cardiac arrest and how there's an electrical, a circulatory, and a metabolic phase. And then we've thought through some of the future therapies that might come to treat especially people who have had long arrests and have gone into the metabolic phase. So using hypothermia and a whole bundle of care to treat these patients to optimize their outcomes. Using bypass if we can't get their heart started again. Using suspended animation or emergency preservation and recovery for patients who have penetrating trauma, hemorrhagic shock, and then exsanguination, cardiac arrest. And then the idea of mitochondrial medicine, manipulating the cell's energy sources, energy production organelles, so that we can let more cells recover after they've been injured, and then taking these patients to centers that are able to do all these things. Thank you very much for listening today.